Hi, this is Greg Stone from the Mount Sinai Heart Health System in New York City, and we're here in Europe, in Paris, at the EuroPCR meeting, where I just had the honor of presenting the final 5-year results from the Absorb 4 randomized trial. And Absorb 4 related to bioresorbable vascular scaffolds. And as you recall, these devices, which are everolimus-eluting polymeric devices, were designed to replace stents. And that is, they completely resorb into the body within 3 years, turning into carbon dioxide and water, and so are completely eliminated from the coronary tree, basically reverting the coronary arteries back to its natural state. So the thought was that these scaffolds could have similar outcomes to metallic drug-eluting stents within about the first 3 years before they absorb, and then hopefully similar or even improved long-term outcomes while again having a body free of any implants. And early studies with these devices suggested that they had increased early rates of target lesion failure and device thrombosis. But we had learned that there were many limitations of the first generation devices. First of all, they were very thick and they had suboptimal mechanical properties, but as or more important, they were also implanted with suboptimal technique. And we've learned the so-called PSP technique. Adequate pre-dilatation, optimal vessel sizing, and adequate post-dilatation could lead to better outcomes. So with this in mind, we designed the Absorb 4 trial, which is the largest randomized trial to date of bioresorbable scaffolds. And in 2,604 randomized patients, we compared them to Xience cobalt chromium everolimus-eluting stents. And we had previously reported and published the 1-year data, and we now have the 5-year data. So at 1 year, there were actually no significant differences between the devices. What we saw now with 5-year follow-up is from 1 to 3 years, there still were slight increases in adverse events with the BVS, the bioresorbable vascular scaffold, compared to the metallic drug-eluting stent. But the differences were smaller than we had seen in the past. It was about a 3% difference in target lesion failure over 3 years and about a 1% difference in scaffold thrombosis over 3 years. From 3 to 5 years, there were no significant differences between the devices. The curves were very similar, and we had previously reported similar findings in the past. And so when you look at patient-oriented events, and when you look at death and cardiac death, almost identical rates between the two devices. So they're getting closer and closer and closer with metallic drug-eluting stents, just with improved technique. The second fascinating thing we did with the study was we looked at recurrent angina. And we carefully collected recurrent angina in this trial, which was a sham-controlled blinded trial, anytime within the 5 years, and had a clinical events committee adjudicate whether it was truly angina or angina equivalent symptoms. And amazingly, within 5 years, 53% of patients in both groups had recurrent angina, more than half of the patients, despite the fact that these were pretty non-complex lesions. At any one time period, which is what we usually ask about, it was in the single digits. But when you cumulatively added it up over time, it was more than half the patients were getting recurrent angina sometime, suggesting that this might be more than just epicardial coronary disease, perhaps microvascular dysfunction or vasospasm or something else. So the bottom line is, from the Absorb 4 final 5-year results, the largest randomized trial of first-generation bioresorbable vascular scaffolds compared to state-of-the-art metallic drug-eluting stents, we still have a ways to go, but the differences are getting smaller with better technique, and I think the differences can be eliminated by, 1, better scaffolds with thinner struts and better mechanical expansion properties, and 2, by more frequently using intravascular imaging in some of the more difficult cases, and hopefully that will be the future studies. In addition, we've really identified this problem of frequent recurrent angina in these patients undergoing PCI, which I think is more than just due to the epicardial coronary lesions. We've got to look at microvascular disease as an underlying cause of angina that contributes in these patients as well. Thanks.